Welcome, everyone, to our Health Policy Outlook series, Ethically Managing the Migration and Recruitment of Nurses to Africa. I'm Nancy Reynolds. I'm a professor and associate dean of global affairs at the Johns Hopkins School of Nursing, and I'm delighted to be moderating this session today. This is really a timely discussion. The global healthcare landscape is witnessing really a significant challenge, the migration of skilled nurses from countries facing critical healthcare needs to those with more affluent healthcare systems. This webinar aims to shed light on the pressing issue of nurse migration and its profound implications. We aim to explore the factors driving this phenomenon, the impact on source and destination countries, and potential solutions to address the critical shortage of healthcare professionals in lower middle income countries in Africa. Today, we have the pleasure of engaging three really expert academicians, leaders, and policymakers and healthcare practitioners. We're going to help us to dissect the complex dynamics of nurse migration, share their valuable insights, and how we can all work towards ethical, sustainable solutions that ensure equitable healthcare access for all. It is my pleasure to begin with a very brief introduction of our panel of experts. And I'll keep it brief because if I shared all of their accomplishments with you, we could take up the whole time to do that. But I encourage you to Google them and to learn about the fabulous work they do. So we'll start with a brief introduction, and then this is going to be followed by just an overview of the situation and then a question and answer session. So our first panelist is Dr. Yvonne Commodore-Mensah. She's an associate professor in the Johns Hopkins School of Nursing. She's a cardiovascular nurse epidemiologist whose current program of research seeks to reduce the burden of cardiovascular disease risk among Africans locally and globally through community-engaged research. She is the president and co-founder of the GDNA, an organization that aims to foster a sustainable local global collaboration between Ghanaian nurses in Ghana and the Ghanaian-Diaspora to advance nursing education in Ghana and improve health outcomes of Ghanaian people. Our next distinguished speaker is Dr. James Avoka Asiami. He is a health economist and health systems expert who works with the World Health Organization as the team lead for the health workforce for the African region. His core expertise is in health systems focusing on the health workforce, health economics, health planning and policy, and decision analytic modeling in health. He's published widely in these areas. And lastly is Dr. Allison Squires. She is a professor at the Rory Myers College of Nursing at NYU and the director of the Global Consortium of Nursing and Midwifery Studies, a 70-country research consortium collaborating on research capacity building projects in nursing and midwifery globally. She has extensive experience in the areas of migration and immigration health, health services, and workforce research, and she has consulted with the Migration Policy Institute and the World Bank on nursing and health workforce issues. So I welcome them, and it is now my pleasure to ask Dr. Yvonne Commodore-Mensah to come and give us a brief overview of this area. Thank you.
Great. Thank you so much, Dr. Reynolds, and thank you all for taking time to be here today. I've been tasked with providing a brief overview and sharing some data, right, to inform our conversation. We understand that in order to make these policy changes, we need to not just go with anecdotes, but we need to make data-informed decisions. So this conversation is a follow-up on a roundtable discussion that happened in Ghana on August 18th. It was organized by GDNA, the Ghanaian-Diaspora Nursing Alliance, and I do want to take time to acknowledge our co-founder, Dr. Matilda Decker, who's one of our adjunct faculty members. So GDNA was started because of a fire drill that happened in this building. We bumped into each other outside the building and started talking, and we both share this passion to advance nursing in Ghana and the African region. And so at this roundtable, as you can see from the list, there were about 20 attendees, including Dr. Reynolds, who joined virtually at 5 a.m. in the morning. We had ICN, CGFNS, the Ministry of Health, and other stakeholders. So we're having this conversation because the WHO Global Strategic Directions for Nursing and Midwifery has specifically highlighted a priority on jobs, right? So we know that this document presents evidence-based practices as well as policy priorities that will help countries ensure that nurses and midwives optimally contribute to achieving universal health coverage. And in this document, they specifically, and I underline this, they specifically came up with a priority on jobs. And the goal is to increase the availability of health workers by sustainably creating nursing and midwifery jobs and effectively recruiting and retaining midwives and nurses and ethically managing international mobility and migration. So another resource that we should all be familiar with is this WHO ethical guide, which informs our conversation. This is the WHO Code of Practice on International Recruitment of Health Personnel, and which was adopted by all member states at the World Health Assembly in 2010. So in this document, they noted that high-income countries should also focus on their own workforce sustainability, but also consider bilateral agreements, improve data and monitoring and workflows of nurses and midwives. But this code also supports a health workforce and safeguard list. It's often called the red list of 55 countries. And so this, commonly referred to as the WHO red list, identifies countries with low health workforce density and a low coverage of essential health services. And the list is dynamic. It's intended to be updated every 3 years. And Ghana is one of the 37 African countries that is included in this list, meaning that there should be ethical consideration when it comes to ensuring that these countries have adequate workforce to achieve universal health care. So I'll quickly provide you some data on the nursing workforce in Ghana. So we know that there are 133 nursing institutions in Ghana, and 64% of them are government-owned. And so in Ghana, for those nurses who attend the government-owned institutions, they go to school for free, but they also get a stipend to cover their living expenses. So just keep that in mind when we have this conversation. And then the other 36 are privately owned. So the data you see on the screen is from the Nursing and Midwifery Council in Ghana, which is the main regulator of nursing in Ghana. So in 2018, there were about 6,000 nurses who were auxiliary nurses, or one would call diploma nurses, and there were almost 14,000 nurses in 2018. But in 2022, NMC reports about 21,000 nurses. So there's been an increase in the number of basic nurses or registered nurses. But then data from the Ministry of Health suggests that there are over 121,000 nurses in the public sector, right? So these are nurses who are employed and paid by the government. And 57% of them are professional nurses, and 78% of the 68,000 are diploma nurses. And one of the findings I want to highlight here is that only 198 of these nurses are what we call specialized nurses or specialist nurses, so advanced practice nurses. So less than 2% of these nurses are specialist nurses. Let's keep that in mind during our conversation. So I want to give credit to Professor Avoka for this slide, which shows the trends in the nursing workforce in Ghana. So you can clearly see that there's been an 840% increase in the number of nurses and midwives from about 13,000 in 2002. And in 2022, it's reported that there are over 122,000 nurses in the public sector in Ghana. So stay tuned for the panel discussion, which will explain why there's been this rapid expansion or growth in the size of nurses in Ghana. with this expansion, there's emerged the challenge of unemployed nurses. And this is, again, it confuses a lot of people. We'll talk about why there's this issue of unemployment. So since 2020, there have been about 21,000 unemployed nurses in Ghana each year. And so it's also estimated that by the end of the year, 2023, there will be approximately 90,000 unemployed nurses in Ghana. And I also want to give credit to the NMC for this slide. This unemployment issue has contributed to what we call outmigration of nurses. So we first have to acknowledge that all nurses have a fundamental right to work anywhere they choose. And so for unemployed nurses, they look to travel elsewhere to be gainfully employed. So the NMC has shown that in 2020, they only had about 2,600 requests for foreign verification. So if you do have to travel outside the country, you need to have your credentials verified. But in 2023, by July, that number had increased significantly to about 5,000 nurses requesting some of these credentials. And so where are these nurses going mostly? Canada, Ireland, UK, and the US of A. So this is not just an issue that pertains to nurses in Ghana. It applies to the entire continent. So in Zimbabwe, there are nurses who wish to migrate. In Kenya, there are nurses who seek to migrate. Ghana, which we're going to talk about, and we'll talk about other examples as well. 65% of professional nurses intended to migrate in 2023. And Eswatini, which is also in the African region, 41% of the nurses intended to migrate. And I also want to give credit to Dr. Squires for this slide, and it shows NCLEX applicants from 5 African countries. So you can see that Kenya, which is in blue, right, and Nigeria in pink, they top the list of African countries who are taking the NCLEX, followed by Ghana in the light green. And I wish I could move the photo so you can see, but the light green is Ghana. So when these nurses take the NCLEX, are they all passing? What's the pass rate? So we know that the NCLEX is a standardized test that measures whether a nurse has the necessary preparation and critical thinking to work as entry-level nurses. So in 2017, only about 1 in 3 nurses from Ghana were passing the NCLEX, but in 2022, about 58% of them passed the NCLEX. So the passing rate is increasing, but it still falls short of the about 80% pass rate in the US. So with that in mind, we thought it would be helpful for you to understand the context for this conversation. And I'll turn it over to Dr. Reynolds, who will lead us in this discussion.
Great. Well, thank you so much. And I hope people online can hear me now. We can
Yes.
take the slides. Oh, great.
Testing, yeah.
Ah, that's better. Great. So we will panel session now, and we'll just put our speakers up on the screen so everyone in the room here can see them.
Rafe, can you help? Thought I did it, but
Just a moment. Ah, great. Very good. So again, thank you for being with us. And I'm just going to start to ask a few of you a few different questions so we can start to look at this issue from a few different angles. And I'll start with you, Dr. Yvonne. Why do nurses decide to migrate, do you think? And, what factors influence it? And, is it economic or?
Well, there are a number of reasons why nurses, not just in Ghana or other African countries, decide to migrate. There are anecdotes, but there's actually a study that the Nursing and Midwifery Council conducted to understand what are the motivations, what are the factors that drive nurses' intention to migrate from Ghana. And so as you can imagine, economics may be one of them, where people wish to migrate to earn more money. And that was actually not the number one reason why people wanted to migrate. One was safer working conditions, right? So there are instances where there are nurses who are working and don't have adequate personal protective equipment. They don't have the necessary supplies. So they learn about all the ways that you can provide high quality care, but then when they're in the workforce, they don't have those resources. So that's the main driver of migration, according to the study that they conducted. But another reason was professional development and advancement, right? So there aren't a lot of training opportunities and ways that nurses can achieve advanced education. So as I presented earlier, only less than 2% of the professional nurses are what we call advanced practice or specialized nurses, right? So a lot of them seek to advance their careers, but there are limited opportunities for them to do so. And so they feel like if they migrate or they go to other higher income countries, they can get opportunities to get advanced degrees, become advanced practice nurses, but also earn a better wage to support their families.
Yeah, and I think sometimes we've heard that nurses can't necessarily find jobs in their own country too. So it's professional growth and also a practical issue too. And I wonder, Dr. Osmani, if you might address, what sort of impact does this have? We can sort of see the personal reasons that people will have for moving to another country to practice, but how does this affect the healthcare systems in low and income countries in Africa? Oh, are you with? Oh, there he is.
Yeah, thank you, and a pleasure to join the discussion. So, as we all know, those who tend to migrate are not the new graduates usually from training schools. They're usually people who have gained some experience over time. And so the impact for the country where they are living is usually that they would go with the experience and would have new people who have to be hired without the experienced one to mentor them. The impact of this directly is poor quality of health services. But also Africa is one of the places, and maybe Ghana included, that there are still shortfall of health workers on the forefront of service delivery. And therefore, migration in a manner that is not planned can lead to increasing service delivery gaps and therefore worsening population health outcomes. And finally, training health workers are more expensive than employing them. And therefore, if migration is unplanned, the impact is that there will be loss of public investment in the training of the health workers, or in particular the nurses. And that is something that, although migration is important, it should be more looked at in a planned manner so that the absence do not become sudden.
So just to follow up, so how are the source countries, how do they cope with the loss of healthcare professionals in your mind? So if they're leaving, how are the source countries dealing with that?
So they deal with it in different ways. One way is what we call tax shifting and tax sharing. If you have a critical care, you find a generalist nurse and give the person a crash course, maybe a week training, or sometimes no training, put them there to learn from the job. So that's a tax shifting. If you have a professional nurse who has left, you bring the associate, and then you put the person in the field to work. So that's how they cope with it. The other one is.
Okay. And let me follow up now with a question.
You provide for 5 minutes, and then
okay, thank you. And I'll follow up now with a question about the other side of the coin to Dr. Squires. So what's the impact on the destination countries in your mind? Is this a positive thing?
Well, thank you, Nancy, and again, thank you for the invitation to participate in this panel. So for the destination countries, of course, there's a benefit in terms of filling staffing gaps, but it really depends on where the person lands. So historically, a lot of internationally educated nurses in the US have first landed in long-term care. They usually work in long-term care for 2 years, and then they'll transfer generally to an acute care setting, because we don't really do primary care all that well here in the US. And so we're looking at, the benefits to the health system. We're addressing we're filling these gaps where we have critical vacancies. And, but the common issue that's underpinning all of this is the retention of the nursing workforce. And if organizations did a better job with how they treat nurses and how they manage their nursing workforce, they wouldn't have critical vacancies that would necessitate actually recruiting internationally educated nurses. So, but it's the same issue in Ghana and many other countries of, there are issues around pay, around work environment, career advancement opportunities that are driving nurses to leave the country because they're not being retained, they're not being valued in their place. So it's the same issue, just different reasons for it across countries.
Yeah, interesting. Mr. Vaughn, what are the personal experiences in your experience? What do people experience when they make a move of this nature?
And to build on Dr. Spire's comment about when people arrive, where do they work, right? So GDNA organized a webinar, and we invited Ghanaian nurses who had migrated from Ghana, but had landed in the UK, in Canada, US, and they provided insights into their experiences. And one of them is the example that and Allison shared, which was that you have a nurse who was perhaps an ICU nurse in Ghana, and they moved to the UK, and they're not working in the ICU, but they're working in a nursing home. And when they arrive, and all nurses have the right to seek professional advancement. So when they arrive and they realize, well, actually, I do want to work in the ICU, they're not allowed to, right? The contracts requires that they work for X number of years, whether it's 2 or 3 years, and if they want to go back to school. And that actually happened with one of our executive team members, where he arrived in the UK and decided, actually, I want to go back to school and advance myself. He was not allowed to. Some of the contracts that the nurses sign in many ways can be considered unethical, right? Because when people arrive and they realize that actually the working conditions here are horrible, and they want to move on to better working conditions, they are told that they have to pay $20,000, $30,000, an exorbitant fee to get out of the contract, right? And for some of these nurses, they may not really have like the legal aid or know, hey, actually, you can renegotiate. If you have concerns about the working conditions and you feel like you're threatening your license, there are other ways out, right? So those are some of the experiences they shared. But they also shared that they were stunned when they experienced discrimination and racism, not just from the patients, right? And this is not a US problem. This happened in the UK, Canada, not just the patients, also their colleagues and the society overall. So there were people who felt like they were not really adequately prepared for the transition. It was painted as a land of milk and honey, and you arrive, and in some cases, a lot of people were not well prepared for the difference in the climate, right? How cold it would be, where to live, and you're told you're going to earn what, $70,000, but you get here and surprise, surprise, Uncle Sam takes a significant proportion of your salary, right? And you also have your living expenses. Where do you live? Which schools do you put your kids in? So a lot of the nurses had noted that they weren't really supported in terms of making that transition from their country to integrating successfully. So it's one thing to recruit someone and just, assign them to a unit, but it's another thing to ensure that they have adequate resources to know who to go to for help. And some actually propose, well, what about mentorship programs or integration programs? So when you arrive and you meet another nurse from Rwanda, right? And they have also made that journey and understand the system and can teach you the workplace culture, that leads to better outcomes.
Those are great points. And I have to say, in terms of some of the nurses I've known over the years, they are also often supporting family members back in their home country too. So they are often feeling a lot of economic pressure that way, as well as trying to cover their expenses in a new. Are you aware of any kind of supports that are available to nurses who make the move? Does anyone do that well?
Well, it depends. It depends on, and I think that's the same comment Dr. Spires made. It depends on where you land, right? So we know that even in the US, as an example, if you were to migrate from an African country and you ended up in Maryland, Maryland is pretty diverse, right? And there are nurses from all over. If you land in New York, right, it's also a very diverse area. But if you land in a very North Dakota, using that as an example, and that's a smaller population, you really may not have that support. But that's one of the reasons why GDNA exists, which is to help create, and not just making a shameless plug, but working with other organizations to figure out how do we support these nurses when they make that journey. So one of the things we're working on is creating a mentorship program for nurses all over, so that if someone is really making that journey and transitioning to a new environment, how do you ensure that they have the right support system? And how do you offer guidance? And that could also include legal support. And that's something we're looking into, so that when you get your contract, before you sign it, get a lawyer, get someone with that legal expertise to let you know if there are clauses or things in the contract that may be questionable before you actually make that decision. But there are a number of organizations. So CGFNS has a list of organizations that also supports internationally educated nurses as well.
Yeah, and if I could jump in real quick.
Yeah, please.
So in many countries, Australia was actually a pioneer in this area, but there's something called a transitional education program, where that can either be supported by the staffing agency or by the healthcare facility that is recruiting the nurse. And this transitional education program goes beyond just your standard nursing orientation. It really helps with housing placement, making sure people are finding housing in safe areas, understanding how school works, taxes work, does all of those sort of cultural transitions, but then also talks about things like, what's professional dress, what are professional manners in the US workplace, those types of things, to really help ease that transition. And, and when it's done well, it can mitigate a lot of those, initial stressors, because even when you're prepared, it's still a stressful thing to move countries. But anything that can be used to help support and ease that transition is important. And the Alliance for Fair and Ethical Recruitment accredits staffing agencies. And part of the criteria is to have a transitional education program support for their nurses when they're coming over.
Right. So I have a question for James. Can you touch on what are the current regulations and policies in place around all of this? Are you still? I wonder if he's still with us. We may have lost him.
Oh, he's there.
He's there, just like.
Is he there? James, we can't see you, but I think we can hear you. Yeah, please go ahead.
Okay. You were asking if there are policies or regulations in place. Yeah, indeed, the area of international recruitment of health workers, there are no strict policies or rules in place internationally, but there are ethical codes and guides for it. So this ethical code and guide, one of it is what Professor Yvonne made reference to regarding the International Code of Practice. But if you look at it also from country by country perspective, we've seen some countries where they have actually put in place mechanisms to help those who want to migrate. And by putting that mechanism, it is not a rule that says you must go through this, but they are like managed migration programs where we can eliminate the exploitative labor practices that we've seen, where people are promised one type of job and they land in the country of destination and get another type of job. People are promised a certain salary, they get there, it's a different case. People cannot change employer within a certain period of time. Many things. Sometimes simply because the level of effort that was required was so little and they did not wait. Sometimes just $1,000 or $2,000 input was made by a company and now they bond the person. So what we have seen is countries now becoming more assertive and saying that if one particular country is recruiting large number of nurses from our country, then let's sit down to discuss the details so that we can have mechanism to guarantee the rights of our workers. And there's a mechanism for them to come back, so they want to come back one day. And we can be sure that they will do jobs that relate to their training and their experience. So more broadly, there are no strict rules about it that has been agreed that are enforceable. There are basically ethical codes, and countries are exploring different ways to be able to ensure that they eliminate the labor exploitation practices, and if possible, also get some economic return for the workers that they train, especially the nurses that they train that they have to migrate.
Okay, so we sort of have these recommendations in place, not clear regulations. I guess I'll throw out to all of you, what are sort of the ethical dimensions of this? Do you think that high-income countries have an ethical obligation not to hire nurses from lower middle-income countries?
I think as we've alluded to, it's a complex issue where if there's this paradox of unemployment in some African countries, the nurses who reside in those countries have a right to work anywhere. And if we have this issue of dire shortage of nurses and nursing homes that are closing or not even accepting new clients because they don't have enough nurses, how do you create a win-win scenario where the high-income country benefits, but the low-income country benefits as well? So what do we mean by that? So some countries have attempted to negotiate agreements with Ghana and other African countries. And I know, for instance, the UK attempted to enter into an agreement with the Ghanaian government, and they offered about £1,000 per nurse that was recruited. And if you remember earlier, I mentioned that for anyone who's trained by the government and they go to school for free, they receive a stipend. And so £1,000 is the value that was being placed on one nurse. And I'm sure all of you would agree that that is not a fair amount to compensate the government. And it's not enough to just say, here's £2,000 or whatever it is. But how do you actually invest in the training of these nurses? And I think that is one of the ethical issues. It's almost like reaping where you have not sown, right? So the government, with very few minimal resources, has done the work of training these nurses. So yes, they are unemployed, but if you're going to enter into an agreement, it's not enough to just provide a dollar amount or a certain amount to the government, but how do you contribute to the training of these nurses? If you visit any of the nursing schools and the skills labs, you'll see that they need support, right? The amazing mannequins that we have, in our simulation labs, a lot of these nursing schools do not have those facilities. So how do we think about, as we take from these countries, how do we reinvest, right, and support the education of nurses, especially specialist nurses? And a lot of institutions like Hopkins, University of Maryland, and across the country have APRN programs, right? How do we enter into collaborations where we help with the education of these specialist nurses? So I think that there are a lot of ethical issues, but one of the biggest ones is ensuring that for whatever agreement is made, that it's a mutually beneficial, arrangement. And the one who benefits, it's not just the high-income country who ends up recruiting these nurses, but also the source country has the opportunity to benefit from the negotiation.
Allison and James, do you have anything to add? Allison, you want?
Yeah, maybe I can add just one thing.
Sure.
Yes. My opinion is that indeed high-income countries are duty-bound and ethically bound to invest in protecting the health systems of the countries they recruit from, if they're recruiting large numbers. We need to be very clear. If a country is recruiting very few nurses from another country, it can be part of secular migration, which is people just trying to move around to, seek other opportunities elsewhere, or maybe just join family. But when there are large number of workers that they are recruiting, training of nurses is more expensive than employing them, like I said before. And it is unethical for a high-income country to rely on the public resources of a low or middle-income country to train for them to just recruit without recourse to compensating for the training of those they are recruiting in large numbers. So joining to what Yvonne has said, it is very imperative that for high-income countries that are recruiting large numbers, they should invest in at least the training of nurses commensurate to the numbers they are getting. They have also argued that we are already, high-income countries have argued this before, that they are already making some investment in health, giving aid for different things. So that should suffice. But my argument is different. If aid is given, for example, to treat HIV, but you recruit the nurse who is supposed to deliver the service, the aid for HIV treatment would not be successful. So you need to make an additional investment to protect the system from the mobility, from the migration. And one of the areas that is very concerning is that there are times even the tutors who are supposed to train the nurses themselves are recruited away. So we take the egg, take the basket, and take the chicken, everything. So I think to that extent, we do need to advocate for high-income countries to make an effort to reinvest in that regard.
Interesting. How about you, Alice?
So, you know, I agree investing in training is critical and an ethical obligation. But what I'd actually like to see is more work done around debt forgiveness, because one of the reasons why a lot of low and middle income countries cannot hire the personnel that they need or cannot employ the nurses that they are producing is because their international debt to high income country lenders can be fairly significant. So they can't create new positions, they can't add and hire into their health system because they cannot afford to pay for these positions. So what I'd like to see is a novel debt refinancing where if high income countries are actually recruiting from low and middle income countries, that they find a way to do debt forgiveness that is the equivalent for each person of not only the cost of their education, but the cost of their experience of higher, you know, of the years worked and the value of that experience of that person that they are recruiting, because that would be a way to, you know, reduce some of the debt burden, but, you know, with conditions that it goes to actually recruiting and retaining and hiring these nurses. You know, if Ghana is has 90,000 unemployed nurses, they don't have a problem producing nurses. What they have a problem is hiring them and bringing them into the health system.
Oh, that's a really interesting observation, Alison, because I was sitting here thinking, do you think ministries of health are going to be motivated, you know, with that debt relief? Will they want to invest it in that way, or will they have other priorities?
Well, and that's the thing is, like, you have to avoid the situation where they're like, oh, let me create, if we're going to get this debt forgiveness, let me create a new physician-led clinic and we won't add nursing positions. So it should really be conditions upon the debt forgiveness that are specific to the professional that is being recruited. So a colleague of mine works in Uganda, and she said, you know, there's one nurse in the hospital on the first floor of 50 patients. And so care gets missed. And it's not that they don't have enough nurses to actually staff that unit. It's that the financing to pay the 2 nursing positions for that unit were actually cut in favor of creating an eye clinic that would be physician-led, because it would be revenue generating. And the cost element there was not seeing the fact that all of that missed care, those longer lengths of stay, were going to cost more than the revenue that the eye clinic was going to bring in, because there weren't enough nurses taking care of people on that unit. So it's those types of dynamics that have to be avoided if you're going to have this type of debt forgiveness situation, and really have that accountability that the money that's being given, you know, the debt forgiveness that's being given and remunerated is actually going to go and be focused on hiring and integrating nurses into the health system.
Yeah, it's interesting. On one of the prior discussions I was a part of, a member from the Ministry of Health was saying that this migration of nurses to high income countries actually presented sort of an opportunity. And they were wondering for their country if they should actually become more like the Philippines, where this becomes a source of financial earnings for the country. What do each of you think about that?
Well, that strategy drives me crazy personally, because it's like it took 100 years for the Philippines to get to that point, and substantial investment over the last 50 years, and making that part of their policy. So I don't think most governments really want to spend 100 years or even 50 years in investing in that type of policy. So that I don't think that's necessarily a good strategy in terms of trying to create a sustainable workforce or a policy for economic development.
And to build on that, yes, the Philippines is regarded as a major exporter of nurses. Most of them end up in the US or UK. But just earlier this year in June or July, when we're at the ICN meeting, we had someone from the Philippines present data. And it turns out that the Philippines actually now has a shortage of nurses, right? So they've gone from exporting nurses to the US and now having this gap because too many nurses are migrating and they don't have enough nurses to provide healthcare for their own citizens. So there's so many lessons we can learn. We cannot copy blindly and say, well, the Philippines has done it, but this provides an opportunity. What can we learn from that model and tailor it to the unique context of each country that may have this surplus? And I appreciate the point that was made earlier, which is that, yes, you may have 90,000 unemployed nurses, but managed migration is one potential solution, but how do you provide other opportunities for development, professional advancement? How do you convert that to training more specialist nurses? So the only solution is not sending them away, but how do you ensure that they receive advanced education? When you think about rural areas, there are a lot of areas that don't have any healthcare. They don't have physicians. How do you ensure that you're training more nurses, helping them to advance so that they can fill these critical gaps in rural areas and improve health outcomes? So migration is one part of it, but there are existing needs that are not met. And we need to ensure that as we have this conversation, part of the conversation also addresses the need to improve the training and professional development of nurses.
Great.
Okay.
James, do you have anything to add to that before I move on?
Yes, very quickly. So there are three main issues. One issue is what we call the need for the nurse. How many nurses and what kind of nurse does the population of a country require? That is an important part for planning and for future policy. But there's also the other part, which is how many nurses can a country, given its current level of resources, be able to employ and support? That we call it the demand for nurses. Then you compare that with what is actually being trained and who is available. That's what we call the supply. Now, in some countries, while in the need is greater than the supply, that means they have a shortage of workers to deliver services, their capacity to employ is limited and they can employ all those who have been trained. And therefore, you have what we call the shortage, which is based on economic-based surplus of nurses. For these countries, and we've seen that in many places, like we've now seen in Ghana, and we've seen that in Uganda, we've seen that in Tanzania, and many other places. They have this paradox where that surplus that they have, unless they find a solution for them, they are going to accumulate over time. And remember that for nurses, when they are not employed over time, they begin to lose their skills, and it's rather more risky than finding a solution for them to work outside. So we are beginning to see that countries said, no, we have shortages, but we can't absorb the people, we want to let them go. And these realities, we need to start thinking about how do we balance it and ensure that some can go and some can remain, and who goes and at what time to go, all of that can be mapped together in the process. That is what really we consider as a managed migration.
Yeah, that's a really important point. And I'll follow up with you, Alison, whether you think we're doing adequate workforce planning and do we even have the right data to do that?
Adequate workforce for where, for the US or globally?
I would say everywhere.
Well, the
You can-
data about nursing human resources at the level of depth and deep detail that would be required to actually do adequate workforce planning is just not there. The World Bank has 27 different categories that qualify as a nurse in a country. And so when if you think about that, it's like, well, and you look at those roles, there are things like the equivalent of what they call dental nurses or dental hygienists. They include nurse practitioners, they include nursing faculty, nursing assistants are in the same category of nursing human resources. So when it comes to the level of detail that we really need to be able to do that kind of work, it's really just, it's not there at the level that we need. You know, the US has good data systems and infrastructure, so do a lot of high income countries. But in terms of being able to differentiate where is demand actually needed, that level of planning really isn't, that's not really there. I mean, the UK does have exceptionally good data there, but they're more the exception than the rule.
Great. As we're getting close to the top of the hour, I wanted to see if any of our participants here had any comments or questions for our panelists. Yes, here, I'm going to hand you.
I was just curious, at the beginning when we were talking about professional development as a driver of migration, are there differences in scope of practice as well that you feel might contribute to that, even separate and apart from going on for an advanced nursing degree?
So scope
yes,
of practice.
Yeah, just like scope of practice for like a professional nurse in the United States versus in one of these other countries. Like, do you think that there are differences there that may impact things?
Yes. And I can actually speak from my personal experience because when I went to Ghana about 5 years ago, I had malaria, and if you've traveled to Ghana, and it's common. And so the physician told me, oh, I have to leave and go start a blood transfusion. And my question was, well, don't you have nurses for that? And the response I got was, well, nurses are not allowed to start blood transfusion. So again, you can imagine my reactions like, oh, well, if they can't, why don't you actually train them? So there may be some differences in terms of scope of practice and what nurses are allowed to do, but that gap can be filled, right? So if there's a program that seeks to integrate them in any setting, do a baseline understanding of what are you, apart from passing the NCLEX, which is wonderful, what are the tangible skills and training that they already have, and how can you fill those gaps? So there are some differences in terms of scope of practice, and maybe starting certain types of medications, right? So there are differences, and they also differ not just by region, but also by country. So if you're a nurse in a more rural area, you can do a lot more. You can function like a physician, you can prescribe. But if you're in a more urban area too, the scope of practice is also slightly different. So it's pretty nuanced, but there are definitely differences in scope of practice. But I don't know if Allison or James have anything to add.
Yeah, Allison, go ahead.
Yeah, so the data actually about what nurses do in each country, we don't actually have a comparable data set where we could say like, oh, nurses in this country, in this job category do this. So we can't even compare that. So when you look, even when you're looking at the literature that's the international literature about staffing, it's like, okay, well, yeah, that's the nurse staffing and the link to patient outcomes in that country, but it doesn't mean that the nurses in each country are doing the same thing. And then you also have the level of technology penetration. You can have very well-resourced hospitals that in low and middle income countries that look just like hospitals in high income countries, and they have the same level of technology penetration. So, a nurse who's worked in that context would have a much easier time transitioning. But, if your ICU doesn't actually include a ventilator, that is a very different ICU nurse role than compared to working in an ICU that does have ventilators. That's just the most basic example. So it's both that intersection of what is the role of the nurse, but also their experience with working with medical technology in their country of origin.
Right. Oh, another question back here. Just a moment.
I'll stand up, but this one may be more geared towards Yvonne.
Yeah.
Oh, but so my question is around like, say, African Americans, you know, it's a big movement around them moving sometimes back to Ghana or relocating or migrating to Africa. Have you heard of any who come with nursing degrees from the US and, you know, work in Ghana?
I'm actually smiling because I think
Yeah.
our co-founder, Dr. Decker, has some insights to share.
Yeah, so actually this past 2 weekends ago when we had our nurse and social, we had a nurse practitioner that was relocating, or not relocating, but moving to Ghana. She was really excited for that. Now, you know, because of the difference in scope, right? That's kind of concerning. However, currently GDNA is currently working with the NMC to create an MOU so that our nurses that are migrating from the diaspora or high income countries that will be willing to support our hospitals or areas that need nurses could do that easily, smoothly, because currently you have to take a board exam and do pretty much clinical rotation for 6 months in the hospitals. Now, you know, between tropical medicine and, you know, working in a high income country, you could only see the gaps and the issues that will be there. So similar to getting a nurse from Ghana, you know, and placing them in a nursing home because it's ICU nurse in Ghana and placing them in a nursing home because they don't have the resources and have not really had experience with ventilators. It's it's a shift, right? It's a real shift. So any nurse that is deciding to go back, and it takes a lot. So GDNA is trying to work with, you know, the NMC to create that MOU to make sure that when our nurses do migrate or decide to go to Ghana to practice, they can integrate smoothly. I hope that answers the question. Okay.
Great.
Well, and also the nurse practitioner role is not in every country. Yes, there are nurses in sub-Saharan African countries who are working at the level of a nurse practitioner, but that is not an actual former licensure or credential recognition. So, you know, again, these advanced practice roles in particular don't easily translate. And there also can be a lot of resistance from the physician community of, you know, of a nurse practitioner coming and working in the country and practicing at, you know, at a similar level.
Yeah, I wanted to add on that too. So as a nurse practitioner myself and, you know, co-founding GDNA, one of our main missions is to make sure that advanced practice nurses or nurse practitioners are well recognized in Ghana. There is something called nurse practitioners in Ghana, but there's no real regulation. There's no true scope. They're under the physicians. So how do we allow the nurses to take back nurse practitioners? So we are working extensively with NMC, and we are hoping to have a roundtable discussion this January to really see, you know, to identify the benefits or to at least put that out there and say, hey, the West is doing it greatly. And so what does that look like for us in Ghana, where there's a limited number of the physicians that are in the workforce or migrating out as well? How do we get these nurses to be specialized in areas or trained in specialized area or become nurse, you know, practitioners? So yeah, GDNA is taking on a lot, but yeah.
Thank you. Yeah, we'll take one more question and then we'll wrap it up.
Sorry.
Right?
Okay. I hope it's a good one then. I was listening to the discussion about the arrangement between countries, high income and low and middle income countries, to pay back or to invest in the education of nurses in Ghana or other African countries in exchange for nurses coming here. But then I worry about, well, you were talking before, Yvonne, about looking at the contract you get from a hospital. I can't imagine but I'm worried that the nurse is going to get stuck in servitude, because now you've got countries that have passed back money back and forth in exchange for this nurse. And now that nurse will no longer have the autonomy that we're really hoping they would have. Anyway, I was just concerned about getting countries involved in possibly reducing autonomy.
That actually has become a commodity, so to speak.
Yes, it could be. But I think Professor Avoka would be better positioned and in terms of his role within WHO Africa, and I have some insights to share as well. So James, I don't know if you have a response to the comment about, is it better to have a bilateral agreement between countries versus allowing recruiters, right, to just go in and recruit from different areas?
Okay, maybe to clarify what really a bilateral agreement can do, a bilateral agreement does not ask for pay maybe X dollars for this particular nurse you are going to recruit. It may say, and let me make it very practical, like the one in Kenya with the UK, that Kenya will provide the UK 30,000 nurses over 5 years. Now, the UK would recruit a certain number of nurses per year from Kenya, and in return, they would provide some support for training of nurses, some exchange programs for tutors to build their capacity, among others. So the nurse being recruited from Kenya is recruited by a recruitment agency and not like the government ships to the UK and take money back. So the bilateral agreement really is just to make sure that the playing field is leveled and that the nurses would have better opportunities, not like a sale, sort of.
Right. And I think the alternative, where we've heard experiences where you have international recruiters, different people who are going in for different motivations, right? Who are recruiting from, for instance, they're recruiting specialist nurses, so they're not doing it in a thoughtful, ethical way. And that's why there's a lot of push for maybe these agreements that have clear boundaries, right? You're not just going to take our ICU nurses or specialist nurses, but the agreement allows certain guardrails, right, that may not exist if you just have someone who randomly wants to, for many reasons, try to take advantage of these nurses. So that's why I think in terms of the ethical perspective, that may be preferred to just making it free for all, right? Anyone could come and recruit. Yeah.
Yeah, and that's a really nice lead in. We're at the top of the hour here, but I've really appreciated all your insights. And I'd just like for each of you to take a moment to add if there's anything you thought a part of this conversation we haven't touched on that you think we should have. And really just to close by saying, what do you think are the long-term solutions and policy implications? So I'll start with you, Allison, and just very briefly.
Sure. So one of the opportunities that the COVID-19 pandemic presented was a way to do things differently. And, I think in general, the production problem around health workers globally has been solved, but what has not been solved is the retention issue. And so finding ways to focus on retention, including in the US, is going to be something that really will address this problem at its root. And, but still allow for the balance of people who want to migrate and, have other world experiences.
Terrific point. James, any last words and policy implications?
Yes, thank you. What I want to say is that with 18% of nurses in Europe retiring soon, in less than 10 years, and with 30% of the physicians retiring, I don't know about the US data, the need to recruit internationally will not stop now or soon. There is opportunity. The opportunity is that migration and the remittances that Africa can get from it is roughly 6% of GDP, which is much higher than some of the sectors of the economies of Africa. I think it's time to look at it differently from a health, but also from a business perspective, to boost the capacity of systems at both sides, high-income countries and low-income countries. Then it can be a win-win situation. Let's do the dialogue.
Thank you. And Yvonne, you get the last word.
The policy recommendation I'll make addresses training and professional development. And that's the lane that GDNA finds itself in terms of how do we think about training as a strategy to retain our best and our brightest nurses in low and middle income countries. COVID-19 has taught us that you can educate anyone, anywhere. So if there are schools of nursing and programs that want to train more specialist nurses, how do we collaborate and partner with these institutions, help with identifying resources, helping to shore up their skills labs, simulation centers. There are no simulation centers really in Ghana and and there are other African countries that lack some of these equipment as well. So how do we partner to advance global health equity and contribute meaningfully to the training of these nurses as a retention strategy so that they can get that job satisfaction and not want to migrate in the first place?
I think this retention issue is so critical. And so that's a last words to end on here. And I thank you all again so much for your wonderful insights, and to everyone who's here for your participation. So